Hello and welcome to this web series dedicated to sharing key insights on tools and technical assistance based on the work that was done in collaboration between BCG and California counties between fall of 2025 and summer of 2026. Today, we'll be discussing service capture. There are four things on the agenda for the day. Number one, why would we focus on service capture? Number two, a brief overview of the service capture process and how one might adapt that to their own specific situation. Number three, some examples of what support materials could look like as a result of this work. And number four, best practices for change management and scaling of the work across several clinics or several programs. In terms of goals for the day, we really just want to understand the value of identifying these service capture opportunities for both counties and also for members. We'd like to learn from the collab team experience across counties in improving service capture to then be able to be adapted to one specific situation, and like to gain some clarity on practical next steps to implement and scale service capture across your county. Now, why did the collab team focus on service capture? We focused on service capture for two main reasons. The first of which is that service capture unlocks meaningful revenue for the work that staff are already doing. In several counties, staff are consistently doing lots of work throughout days, weeks, and months during the year. And a small portion of that work is going uncaptured. Whether it isn't recognized, documented, or coded as billable, for some reason, a proportion of the work that is being done that is eligible for billing is not being captured as such. So throughout this effort, we are closing that gap. When you close that gap, it converts the staff effort that already exists into reimbursement without adding additional caseload. Now, finding these small gaps here and there, scaled across several staff members, across several months throughout the year, can add up into meaningful dollars that can help sustain the services that folks deliver on a consistent basis for years to come. The second reason would be that service capture can often reduce staff confusion and even lighten the documentation burden. In our experience, we've seen with several staff members that documentation burden exists with that mental friction in not having full clarity on whether or not an activity is billable or what they need to do to substantiate the service when completing documentation. So a large goal in this effort of service capture work is to be able to clear up that ambiguity and give decisiveness to the frontline staff members as it pertains to documenting services so that they can continue to deliver those meaningful, direct services to clients who need them the most. Throughout the work that we've done with counties, we've developed a repeatable 5-step model for high fidelity, high integrity FFP uplift. I'll give a brief high-level overview of these 5 steps, and then we will proceed to do a deep dive into each of these steps and provide an example of what one of them might look like. It's important to note here that although we'll be providing examples, in practice, it can look different than the examples we are showing. And so it's important to keep that in mind and how you might adapt the work that we are showcasing today to the specific circumstances and situations that exist within your clinics or within your programs. Starting from left to right here, step number 1 would be to map the current state workflow. What does this look like? Mapping the current state workflow is essentially taking a look at what the client journey is from start to finish for each staff member within that specific program. Now, for today's example, we will be talking about an access clinic, but you can apply the same principles to any clinic in any program. The goal here is to understand how a program operates, document that experience for the client from end to end among each of the role types that exist within that specific program. Now, step number 2, once you've mapped out that workflow, there are going to be some key areas in which confusion, ambiguity, and opportunity exist. Once you've determined what those areas are, it's important to prioritize which opportunities you want to discuss in order to maximize the FFP impact of that review. The goal here is to establish shared standards and an implementation plan of what you are going to do with that prioritized list of opportunities. The third step here is to standardize interpretation and select a method of support. So once you've determined what the priority list of opportunities are, you're going to want to discuss one or a small subset of those opportunities and collectively agree across program, across quality, across fiscal on what is the definition of the thing that we are discussing today. Under what circumstances would it be billable? Under what circumstances would it not be billable? And then is there any material that we need to create, whether it be a quick reference guide, an additional training, a workflow mapping that will help stand up this best practice state in the future. Step number 4 would be operationalizing and driving the adoption of this newfound billing guidance. So once you've determined the interpretation and selected the method of support in step 3, you know what needs to be changed in the workflow or in terms of support materials. The goal now in step 4 is to operationalize those changes and drive adoption throughout the staff that are involved. We want to embed these changes into daily practice by updating the guidance documentation, training staff, activating supervisors, and sharing out the information as a result of step 3 throughout the entire clinic or program that you are focusing your efforts on. The final step here would be to scale and replicate this work. Oftentimes when we do this work, we'll focus on a specific clinic within a specific program and carry out this work from front to back to be able to truly flesh out any of the kinks that need to get adjusted prior to the scaling and replication across other clinics within that program, and ultimately the scaling broader than just that specific program that it started in. And so for our example here, we conducted the work in an access clinic. The work could then be scaled to other access clinics within the county, and ultimately the work could be scaled to an adult system of care, a children's system of care, or an SUD program within that county. Now we'll quickly do a deep dive on the first step in this process. So what does this look like specifically in practice? Well, when we mapped the entire client journey, what we did was conduct staff interviews and ask throughout the entire workflow within your specific program. Today we're talking about access. What are all of the activities that you do with the client from when you have that initial contact until ultimately they're transitioned to a level of care? What are all of the things that you do? Once we discovered all of those activities, we were able to get that consolidated list and pressure test it with the members to ensure we got everything right. The next step in this process is to identify or document each potentially billable activity within that specific workflow. So when you're dealing with a workflow, you need to identify A, what are the activities that are currently being billed for? And then B, what are the activities that could potentially be billed for as we compare the workflow against DHCS guidance? You then arrive at a list of activities that are potentially billable. And so what we've outlined here on this page is all of those activities through triage and screening all the way until client remaining in access for up to 1 year. The next step within this process is to actually create a short list of program activities where there are unclear or inconsistent billing practices. You'll notice here, the bulk of this page is occupied by a category where some of the billing conditions are met. Now, this is a subset of the complete list that we saw on the previous page. You will also notice that beside each of these activities, there is a cell phone bar indicating the potential FFP uplift based on the length of activity, the frequency of the activity, and current billing practices, bucketed out into low, medium, and high. We have chosen to flesh out an example that is a high potential FFP uplift in researching client case management. And we'll deep dive into that specific opportunity in 2 pages. But before we do that, I'd like to discuss the 3 main steps that go into discussing that activity once it's been selected. So the first step, select the one shortlist activity that you would like to review. We've done this based on FFP impact priority, but of course you can apply your specific county context in making that decision. Once you've done that, you need to determine the required decision makers, whether that be clinic leadership, QI, finance, some clinical team representatives, other frontline staff members, or a program lead. Once you've done that, confirm executive sponsorship and approval authority with that specific opportunity, whether that be with program leadership or executive leadership. And lastly, you want to define the decision rights or governance structure that is associated with what is going to happen in the next 2 steps. It's important to do this work up front to determine, hey, who is going to say yes or no, final pen on whether this activity is billable, and then how are we going to share the load of work that is required to create training materials or support documents that can help stand up that agreed upon future best practice. So step number 2 here is collectively interpret the DHCS policy. So as a group, it's important to take a look at a specific opportunity, read the DHCS policy, gain an understanding of what is truly being discussed in that moment, and then agree upon, yes, this is something that we're going to bill for, or no, this is something that we will not bill for. Or a third option that frequently arises is, here are the conditions under which we would bill for an activity, and here are the conditions under which we would not bill for that activity. This is something that can occur either in person or virtually. Conducting a working session with folks who represent all aspects of the team, we can then determine this third step, determining which workflow and training changes are needed. So if it's something that needs to change within the workflow, a practice that is currently being done that needs to stop being done, or the opposite of that, something that is not being done that currently needs to be done, making those updates and disseminating that information with folks. And also, if there needs to be specific documentation expectations, support materials that could be provided to staff to help stand up this new practice or this new guidance, it's important to determine what needs to be done during this session. So here's an example of a specific activity within the Access workflow that we've decided to discuss today. This example would be researching client case management, and there are 2 real components to the discussion. The first component would be billing conditions, and the second component would be DHCS policy language. So as I alluded to prior, it's important to understand as a group, what are we talking about? Well, researching client case management for this specific example is doing research to determine whether or not there are certain programs that one can refer a client out to. And so when we go into the billing conditions here, synchronous contact with a beneficiary or provider. This is a condition that was occasionally met. Qualifying as a referral or monitoring activity, this was a condition that was consistently met. Linked to identified need and greater than 8 minutes are also 2 things that were consistently met. And the last 2 pieces here, not purely administrative or internal research, and research outcomes are presented to the client as options. These are two other conditions that were occasionally met with this specific activity. We then took the DHCS policy language and had a discussion with all folks involved to ultimately determine under which conditions are we going to bill for this activity. Here is an example of the result of that discussion. And so you can see here, there's a spectrum of billable to ambiguous to not billable. Within billable and ambiguous, there are certain conditions that need to be met with examples. Something that might be billable, a live call with a housing agency to coordinate intake for a client experiencing housing instability impacting treatment. That's a very clear example of a situation in which this activity might be billable. Now, in the middle here, something that might be ambiguous, 5 minutes researching programs online, plus 10 minutes of a live call confirming client-specific placement criteria. And an example of something that would not be billable would be simply searching housing programs without contacting the client or the provider of those programs. After you've determined what conditions need to be present in order for something to be billable, you can then do the following things. Number one, update billing guidance. Number two, inform and activate staff. Number three, continue to monitor and refine the process as you continue to get input from staff members who are involved. We'll do a quick deep dive here on updating the billing guidance. Here is a county-specific example of the opportunity or activity that we had just discussed. So here we have a one-page decision tree of to bill or not to bill. It takes you through all of the mental decision points that you might need to make when determining whether or not the activity that you just conducted that you are about to document is billable or not. Now, this is simply just an example of a support system that can be produced as a result of this discussion. Some other examples might include role-specific documentation guidance, explaining what codes can be used and what documentation should look like for each of those service codes, or things of that nature. It can truly look and take shape in several different ways. Next, we'll discuss what a communications plan and a training plan could look like when implementing and rolling out these changes. On the left-hand side here, we have a communications plan that stems from the deputy director all the way to the frontline staff. It's important to call out here that there is a case for change, timing, and a specific communication channel associated with each of these. This is important to note because the execution of these steps is really important to enable the buy-in from the top down. So once you enable that buy-in, it's great to see the results of the work truly coming to fruition when all folks are aligned on why this is being prioritized. Now, on the right-hand side, we have an example of what a training plan might look like. A training plan here could look like identifying the appropriate staff for training. In this example, clinical supervisors, social worker threes, and clinicians. Then you would need to identify the trainers involved. For here, it could be a quality representative, a program manager, and a finance lead. You could then sequence these trainings throughout the year to be able to reinforce the work that is done on the front end. Practical next steps here could be appointing a lead or a point person, oftentimes a quality team member, to own the cadence of these trainings and own the materials necessary for conducting these trainings. Another useful tool when rolling out some documentation guidance changes can be a RACI matrix. Now, what is a RACI matrix? A RACI matrix defines who is responsible, accountable, consulted, and informed for each step of a process. In this example, the process would be updating billing guidance. Now, what is a RACI used for? It is essentially a governance mechanism to make sure that these changes roll out smoothly and things don't slip through the cracks when trying to implement something new. When is a RACI used? Well, a RACI can be used when trying to roll out changes such as documentation guidance within a county behavioral health clinic. Here is a quick example of what a RACI structure might look like in practice. Now, this is just an example, and it can be adjusted based on specific county context. But for this example, it's important to call out that there are several denotations on the bottom row here. We have responsible, accountable, consulted, and informed. The most important piece here would be responsible. Who is doing the work to complete the task? This is essentially the piece that ensures that the work is not slipping through the cracks and it will continue to get done. Accountable, it's the last person who has the final say on reviewing before a task is complete. Consulted, essentially providing input on what the results of the project will be. And informed here, it's just to bring them along, keep them in the loop, and ensure that if they have any final decisions or opinions, they can share that. It's important to call out that we've shared some general approaches that can be used when operationalizing change and driving adoption, but driving sustained change is very hard. And so it's important to be able to continue to iterate and adapt these changes based on feedback that you get from the folks that are involved in the process to continue to make them more and more personalized and enable that buy-in as time goes on. The final step in this process is to scale standardized workflows to support best practices billing across all program clinics, locations, or facilities. So once you've run this process front to back in one specific location, you can then scale it to other clinics. Once you've scaled it throughout all clinics in a program, you can then start thinking about scaling it to other programs within your county. This is truly an amazing process because it is very lift, refine, and shiftable across several programs in a county. And so you can truly amplify the impact of the work by doing the work, making it adjustable to other programs, and then implementing that process throughout those programs. It's also important to note that you can use the experience that you gain when doing it once to inform any adjustments that you may need to make when doing it again. Thank you so much for joining me today in discussing service capture. Hope that it was all informative and enjoyable. Enjoy the rest of your day.